Hello, our chosen group topic is global maternal morbidity and mortality, specifically HIV in pregnancy. This presentation was created and presented by Maddie Kendall, Olivia Longbottom and Madison Suter. So what is HIV? HIV, or human immunodeficiency virus, is an infection that attacks the host immune system, in particular the white blood cells of the body. HIV essentially breaks down these white blood cells, which in turn weakens a person's immunity to other common infections, making it harder to fight off diseases and infections such as severe bacterial infections, fungal infections, tuberculosis, and some cancers. HIV is transmitted from person to person through bodily fluids, specifically by one's blood or semen. So what's the treatment for HIV? An important thing to note is that HIV can be treated but not cured. The treatment for HIV involves anti-HIV drugs, commonly known as antiretroviral therapy, or ART. These medications are used in a HIV-positive person to assist their immune system to keep them healthy and free from other diseases and infections, while also decreasing the chance of passing the virus to other people. These medications are deemed safe to use during pregnancy, as the same medication regime is used in pregnant women and non-pregnant people. Women who are HIV positive before conception and pregnancy that are on a successful regime may continue this regime into their pregnancy. So how does HIV affect pregnancy? If a woman is diagnosed with HIV during pregnancy, it is important to begin antiretroviral therapy, or ART, at the earliest possible time and educate the woman on the effects of HIV positive status on the pregnancy, the fetus, and the postpartum period. Transmission during pregnancy. It is important to understand the effects on the fetus during the pregnancy, the birth, and the postnatal period. During pregnancy, HIV can be transmitted to the fetus through the placenta, infecting the fetus through the maternal fetal blood system of the umbilicus. During labour and birth, HIV can be exposed to the fetus through the spontaneous rupture of membranes by which the infection travels into the amniotic sac. HIV-positive women who may be advised to undergo a caesarean section birth to prevent transmission of the virus to the fetus, usually before the onset of labour or the rupture of membranes. Although a caesarean birth is recommended in the setting of HIV-positive status, the woman's autonomy for her birth choices should still be taken into consideration. A vaginal birth may be able to be facilitated depending on the woman's individual viral load of the virus, as well as taking extra precautions and considerations of the care during the labour and birth period. Postnatally, it is advised for women to use alternative methods of feeding their newborns, such as artificial formula due to their HIV status. It is reported as the safest method of newborn feeding in Australia, as clean water is readily available to prepare artificial formula for supplementation. Access to clean water may not be easy in other countries, so breastfeeding is the preferred feeding method, increasing the likelihood of the newborn developing the virus. Breastfeeding for some women is a rite of passage and is considered the normal way to feed their babies, so we should still try and facilitate this if possible.
The incidence of HIV diagnosis remains low and stable since 2006 in Australia, and very few people have died of HIV in Australia. Australian pregnancy and midwifery care helps to reduce the incidence and vertical transmission of HIV to infants. More culturally appropriate care and preventative care and education is needed to protect Aboriginal and Torres Strait Islander women from HIV transmission, as the rate of new HIV diagnosis in Aboriginal and Torres Strait Islanders increased by 41% from 2013 to 2017. However, the rate of new HIV diagnosis in non-Aboriginal and Torres Strait Islanders remains stable across a 10-year period from 2006 to 2016. The rate of HIV in Australia, particularly in women, is low at 0.1% compared to the global prevalence of HIV at 0.7%. Approximately 29,090 Australians have been diagnosed with HIV in 2020, with a diagnosis of women at 0.7 per 100,000 women in 2016. In 2016, Aboriginal Australians had higher rates of HIV diagnosis and had 3 times more often diagnoses compared to the non-Aboriginal and Torres Strait Islander population. The transmission from HIV to the most severe form of immunodeficiency, AIDS, is extremely rare. 0 women were diagnosed with AIDS in 2012, and 315 women died from AIDS during 1981 to 2012. In Australia, it is considered a disease which is chronic but can be managed appropriately with pharmacological medications. The protective measures to reduce the incidence of HIV in Australia include the Reduce Stigma and ad campaigns promoting HIV testing, care during pregnancy to reduce transmission to the new infant, and promoting the use of PrEP and ART. Women with HIV-positive sexual partners can access PrEP, which is pre-exposure prophylaxis, and ART, to reduce viral load to an undetectable level. This process is affordable as HIV antiviral medication is on the pharmaceutical benefit scheme and readily accessible in urban areas. Available for women with HIV in Australia include referrals to specialist obstetric care and infectious disease consultants, offering a screening of HIV in the first antenatal visit and education on breastfeeding with HIV, which is not recommended due to transmission risk, referrals to a lactation consultant for lactation suppression and washing all visible blood on baby at the time of birth, using standard precautions such as gloves and gowns during delivery, and women who have HIV can birth vaginally or via caesarean. However, a caesarean delivery is still recommended for women with HIV who have a detectable viral load before delivery, especially if it is above 1,000, are not taking ART, and have other risk factors which require a caesarean.
Thank you, Olivia, for that information regarding HIV in Australia. In subsequent slides, we will be discussing Sub-Saharan Africa and how the morbidity and mortality is compared to Australia. Sub-Saharan Africa accounts for 71% of all HIV diagnoses globally, so that is why it was selected as a feature point in our presentation. It has the highest incidence of HIV in the world. Morbidity. Although HIV can often be stereotyped as a disease held by men who have sex with men, it is often women who face this diagnosis in Sub-Saharan Africa. So young women and girls, approximately 5.7 million young women and girls have contracted HIV in Sub-Saharan Africa, and that is 6 times more contractions compared to men in the same area. So vertical in transmission of HIV to infants in Sub-Saharan Africa is higher than the global incidence. So the vertical transmission rate is about 0.7%, and the global incidence is about 0.2%. And this is due to the reduced incidence of HIV diagnosis at the time of conception and ultimately the high prevalence of HIV in the area. Many countries across Sub-Saharan Africa, particularly Botswana, has eliminated vertical transmission of HIV to infants just because of their increased ART and PrEP rates. So, for example, pregnant women in Botswana, over 95% of pregnant women with a HIV diagnosis are taking ART programs and have a undetectable viral load, so they therefore cannot vertically transmit HIV to their infants. So the mortality of HIV in Sub-Saharan Africa is difficult to determine due to lack of official reporting. However, it is significantly high compared to the rest of the world and especially compared to Australia. In 2016 alone, approximately 300,000 people died of HIV/AIDS, and that is compared to the 0 people even diagnosed with AIDS in Australia from 2012. So obviously quite significant. And the reason why the mortality rate and the conversion of HIV to the more severe form of AIDS is so high is due to the high expense of ART and PrEP medications, the lack of education and the lack of funding to hospital and care resources. So therefore there is quite a high mortality rate in Sub-Saharan Africa compared to Australia.
So in this slide, we'll be looking at pregnancy and midwifery protective factors to reduce the morbidity and mortality of HIV in the sub-Saharan Africa area. So on the positive is ART and PrEP medication has become more accessible since 2005, and the comparative cost of both ART and PrEP in African regions is significantly less than it is in Australia. So it is therefore more economically accessible. The United Nations has introduced gold standard recommendations for the prevention and to reduce the prognosis of HIV. And that is ensuring that women be tested for HIV at least once, attend at least one antenatal visit, and being provided education during that antenatal visit about the incidence of HIV, what the virus is, how it's treated, and how it affects pregnancy. I also wanted to compare pregnancy care in South Africa to Australia. So there is similar technological and educational similarities between Australia and South Africa. However, HIV care differs. So in South Africa, they offer repeated HIV testing antenatally, even if initially negative. This is because the chance of contracting HIV during pregnancy is just so high that they need to continually retest. Additionally, it's much more holistic, and they do ask that men and partners test for HIV for further treatment and prevention in the community. So if one woman is accessing antenatal services, it is helping to prevent HIV in the whole community. And additionally, like Australia, they do begin lifelong ART as soon as HIV is confirmed in pregnancy, and that is the same as Australia. And as I said before, it is more economically available than Australia. And lastly, we have our summary slide. So for a more equitable global society, a focus on women, girls and babies in sub-Saharan Africa, where the highest incidence of HIV is needed to reduce their risk of HIV and eventually eliminate the virus. That is compared to Australia, where there is exemplary control and almost elimination of the HIV virus. We need to examine factors which lead to HIV prevalence in our Aboriginal and Torres Strait Islander communities, as there is an increased risk and increased proportion of Aboriginal and Torres Strait Islander communities having HIV compared to non-Aboriginal and Torres Strait Islanders. And additionally, we need to increase ART, PrEP and midwifery healthcare to reduce the global morbidity and mortality of HIV. Thank you so much for listening.